Hi everybody, we're going to get started on chapter 15 now. So let me get the slideshow going. All right, so we're going to talk about adrenergic agonists, antagonists, and beta-adrenergic antagonists. So remember, agonists versus antagonists, working for, working against, whether it's alpha or beta. Alpha, beta are in the sympathetic nervous system. So one thing to remember is think of an umbrella. The autonomic nervous system is on the top of the umbrella. That's the name. But underneath it, you have the sympathetic and the parasympathetic nervous system. So they're divided into two parts, which I talked about on the last slide set. And this is the picture, and it's a really good picture to look at. Print out. Actually, you can Google it, and there's many different pictures, and maybe another one that would make it a little easier for you to understand. So remember, the rest and digest is the parasympathetic, and the fight or flight is the sympathetic. Now, fight or flight, just remember that it actually relaxes the bladder here, and it also relaxes the intestines. So sometimes we thinking everything is supposed to constrict, but not necessarily. Think of it as fight or flight. Everything needs to be moving. So adrenergic, what is the definition? So it relates to nerve cells in which adrenaline or epinephrine, norepinephrine is another hormone similar to epinephrine, acts on a neurotransmitter. So adrenergic means that it's stimulating it. And there's some vasopressors which are adrenergic, and that is used for a multitude of things. One of them in a critical care unit, perhaps, if you're trying to keep somebody alive and you can't keep their blood pressure, get their blood pressure up, so you put them on these IV vasopressors. If you look at phenylephrine here, that's in Sudafed PE. Instead of the pseudoephedrine here, that's Sudafed, the stuff people use to make crystal meth, so now you have to get it behind the counter at the pharmacy. Phenylephrine, you get over the counter. This right here is actually used in nasal sprays, so your Afrin nasal spray, as well as other brands of nasal spray. So agonists versus antagonists. So this is just one example. Let's think of agonists here that activate the opioid receptors here in the brain. So that would be your heroin, your oxycodone, methadone, hydrocodone, that's Vicodin, morphine, opium. An antagonist is working against. And I know we talked about Narcan or naloxone in the last unit or a couple units before. And remember, it's used to work against, so it's blocking the receptors. So this is an example of what adrenergic agonists do. So agonists, remember, they stimulate the receptors. They actually go to the receptor site, and they constrict blood vessels, heart rate, dilate your bronchioles, dilate your pupils, but then down here it relaxes everything, so then you'll be able to, peristalsis starts going, and then you have to run to the bathroom. So the main adrenergic receptors are, remember, beta-1 and beta-2. B1 is heart and beta-2 is lungs. You have one heart and two lungs. You have two alpha receptors that are mainly in your blood vessels. There's also receptors in all of these other places, so as well as the beta cells, although it's mainly in the bolded area. So when you're giving that medication, you have to keep in mind that the beta receptors is probably in other places in the body. Don't worry about your beta-3 receptors. And the effects of adrenergic agonists at receptor sites is your bronchioles, remember, are going to constrict, they're going to constrict if you take that. So that's why albuterol, actually they're going to dilate. So when you're taking albuterol, it's actually going to dilate. And as well as the beta-1 receptors are at your heart, beta-2 are at your lungs. So we have direct acting, we have indirect acting, and mixed acting. So there's three different kinds. You don't have to know all of you don't have to understand that you don't have to memorize that there's three different kinds, but just know that there are. So there's epinephrine that's working directly on the receptor sites, and amphetamines, and then there's ephedrine. Amphetamines would be your Adderall, your Ritalin, and also methamphetamine. So epinephrine, that is an agonist. Non-selective versus selective just means that it goes everywhere in your body versus selective is a little bit more selective that tries to hit target areas in your body to be able to work just in that area so you're not getting as many side effects. So it works on alpha and beta cells, and there are some contraindications, although if you need to give epinephrine, usually you need it for a reason. So there's some cautions here if you already have a cardiac dysrhythmia, because remember, it's going to really get your heart rate going. If you already have high blood pressure and you're putting more adrenaline in your body, it can be a warning sign for stroke, hyperthyroidism, diabetes, and pregnancy, of course. Always have to be careful, but if someone's coding, you have to give the epinephrine. So it's a vasoconstrictor, it's a bronchodilator. That's the action. So epinephrine continued. I would like you to look in your drug books and see if there's any more side effects or adverse reactions to it. Drug interactions, some beta blockers can decrease the action because beta blockers are actually decreasing the workload of your heart and slowing your heart rate down. So if you have both that on board and the epinephrine, it may counteract it, or you may need a little bit more epinephrine. Digoxin, because that also slows the heart rate down. Also, TCAs, that stands for tricyclic antidepressants. Amitriptyline is one of them, and that's used for depression. And MAOI inhibitors, that is another antidepressant. We talked about that a couple units ago. No tyramine, no chocolate, or anything like that. So basically what it's saying, if you give epinephrine, it can prolong the effects of it. You want to watch for the IV site. It's given through the IV or it's given IM. If someone has an EpiPen, it just goes right through the clothes in the thigh, so it's very easy to give. But if it infiltrates, it can cause necrosis, because think about all the vasoconstriction that's going on in your body with this epinephrine. It's constricting your vessels. So if the IV blows and it's getting into your tissues, it's constricting all those vessels and you're not going to get any blood flow. So if that happens, you need to give this phentolamine, or Regitine is the brand name. Also, any of these drugs, remember the oxymetazolisone in the Afrin nasal spray, you don't want to take it for a prolonged period of time, because actually what can happen is you can become addicted to it and your body will end up needing it. It's just hard to taper off of it. All right, here's one example also. So this is selective, meaning it gives you side effects, but it is more selective, meaning that it really works in the lungs. You have to be careful because it does increase your heart rate and stuff. But again, people that need Preventol usually need it, because what this does is open up the bronchioles. Remember, it's at the using the beta-1 and the alpha-1 receptors, but sometimes it can hit the other receptors, the alpha and the beta receptors. But what this does, it's an agonist, so it goes to the receptor sites to open up the bronchioles so somebody can breathe. So it's an agonist. It's stimulating it. Side effects, people usually get tremors, nervous, palpitations, tachycardia, especially people with anxiety already. So you have to be, tell them this is normal. It's going to go away in about 15 minutes. There can be some interactions with the tricyclic antidepressants, MAOI inhibitors, and there's not very many people on the MAOIs, but you will see people on tricyclics, which is your amitriptyline or nortriptyline. And again, it can work against the beta blockers. So as far as doing the nursing process with these types of drugs, you just need to know the health history, the drug history, to make sure there's not any interactions. How are they sleeping? Because this can keep them up. And also, another nursing diagnosis could be knowledge deficit related to drug administration. And this is an example of tissue necrosis from epinephrine IV. So this could be possibly, it rarely ever happens. But anyways, just so you understand what some of the complications of that can be, that would possibly be nursing diagnosis and an intervention evaluation. But think about what these agonists are doing to in your body, and that will help you come up with a nursing diagnosis as well as teaching the patient. Now we're talking about a different kind of agonist. So this is still working on receptor sites. This is a central acting alpha-2 agonist. So this is really working on blood pressure. It's also working on the brain receptors. It's called Clonidine. Clonidine is for hypertension and pain. We use it mainly for hypertension now. For people that are addicted to narcotics and we want to taper them off, sometimes we'll add Clonidine to it to help them taper it off. So what this can do is it also can cause your heart rate to decrease and decrease the cardiac output. Adverse effects, think of dry. People get dry mouth from this. Also, you can get when you get the dry mouth, you can get the xerostomia in your mouth and tongue. Rebound hypertension, if you cannot stop this drug right away because your blood pressure will come back even higher, can cause drowsiness. We tell people to take it at night before bed, as well as it can cause some abuse. I have not seen that as an issue because we're not really prescribing it as much anymore. But the one thing to remember is don't stop it right away. Methyldopa is another one. It's similar to Clonidine, but there's a contraindication to hemolytic anemia, so you have to make sure you get a Coombs test. And if it's positive, you don't want to give it because Clonidine has an adverse reaction, a rare reaction to destroy red blood cells or can make it worse. So it's given orally. Also, Clonidine is given transdermal, meaning like a skin patch. Also, you want to make sure you get some labs. We talked about the Coombs test. Now let's talk about adrenergic antagonists. Now we're blocking the receptor sites. We're blocking the adrenergic neurotransmitters, so alpha and beta receptor sites. So there are two types. There's alpha and beta. Remember we talked about alpha and beta. Now it's just working against, so meaning it's blocking the receptor sites, which I already talked here on wrote my messy handwriting here. But what this does is vasodilate. Sometimes if you have vasodilatation, your blood pressure drops, you can get dizzy. Reflex tachycardia is basically when you stand up from a laying or sitting position, and you can get tachycardia just by standing up, which is more so pronounced if you're taking these medications. Your pupils can constrict and also can suppress ejaculation. Some of these drugs are used for people that have prostate problems. And this funny, lovely picture I have here is actually, I'll start over. You have the prostate right here that you can only assess through the rectal area, but think of in front of it your bladder. So you have your bladder in front of it. So what happens is you have your urethra coming from your kidneys. That's kind of directly in front of that also with the bladder. What can happen as you get older, this prostate can become larger. And then men have trouble with dribbling. They can't get the urine out because it's closing up the urethra. Once it's completely blocked, then they have urinary retention and they can't pee at all, and they end up in the emergency room and they have to have a catheter in and have a consult by a urologist to resecting the prostate, so that can open that up. But there's medications that can help if there's partial blockage, if they're enlarged, prostate's enlarged, by actually relaxing the bladder urethra here so it can open it up a little bit. So hopefully they can urinate and not have any more issues. The beta-1 and beta-2, remember these work in your lungs, and alpha is in your heart, and it reduces contractility, it decreases your pulse, bronchoconstriction. So remember, if you're giving something for your blood pressure, and you have to watch if someone has asthma or COPD, because if you are targeting the beta-2, if you're blocking it, then you can actually get the opposite of constricting it. Oops, let me go back here. Okay, because remember, just to explain a little bit better on this, beta-1 and beta-2, if your beta-1 and beta-2 actually dilate your bronchioles, but if you block the receptor sites, you're going to block them, this isn't going to happen. It's actually going to constrict. So that's why when you give medications to people with asthma or COPD, sometimes it can hit those sites, and so you have to be really careful with that. So the blood vessels are most effective. I talked about the prostate already, hypertension. Pheochromocytoma is your adrenal gland. This picture here is your kidneys, and you can actually get a tumor on top of your adrenal glands. These are your adrenal glands, but you can get a tumor, and so you're going to have issues with that has to do with your cortisol level. It also helps with blood pressure regulation. So that can actually cause, these blocking agents can cause issues with pheochromocytoma, so you have to be careful. You don't need to know this for your exam. Raynaud's. Raynaud's are these pictures over here. Your blood vessels are constricting, so if you have to be careful about taking alpha adrenergic agents because it can make this worse. Because remember, it's constricting the blood pressure. So just be aware of that. People have Raynaud's anyways, which is the constriction at the distal extremities, and we give other medications to help dilate the vessels, such as calcium channel blockers. You can have orthostatic hypotension. We talked about all of these before. So about the ejaculation with these drugs, what happens is the blood vessels are dilated so much, or the urethra is, the ejaculation actually can back up into the urethra and go into the bladder instead of out because they're not having the constriction to be able to get it out. Here's beta blockers. These are for blood pressure. Beta blockers are all of these listed here. All of these are still on the market. All these you'll hear about. Some are just first generation, second or third. First generations are the first ones that came out, and then second, then third generation. Sometimes the third has more side effects or less side effects than the first generation. Excuse me. Coreg and Bistolic are one of the newer ones. They also hit on alpha and beta, but all of these are different. Some may hit more on the alpha versus the beta, or the beta versus the alpha, or both of them. So it's basically just what they're called, beta blockers. They block the beta-adrenergic receptors, such as adrenaline. So by blocking the action, they relieve stress on the heart. They lower the heart rate. They lessen the force in which the heart muscle contracts, which I said right here. And a good way to remember beta blockers, it has LOL at the end. Metoprolol, betalol, labetalol. So if we go back here, see they're all lols. That's the easiest way. That's a beta blocker. Reduces workload on the heart, makes it try to rest a little bit. It's used for angina. Angina is people that have spasms in their arteries from blockages, hypertension, cardiac dysrhythmias. People that have had an MI have to be on a beta blocker. You don't want to overwork the heart. There's some reduced perioperative mortality. It might not. There's some new research out there that we're not really even sure about that. You don't need to know that for the exam. Heart failure, hyperthyroid, and migraines. It's been used for migraine prevention for years now because there's a thought that if you relax the vessels, then it won't trigger a migraine. There's thoughts whether migraines are actually a neurological problem or a vascular problem. The jury's still kind of out. I think we're leaning more a neurologic problem at this point. Stage fright. You can give Inderal or propranolol for people that are afraid to talk in front of people, and it actually relaxes you. It has a little anti-anxiety effect to it, which is nice. All right, so some adverse effects though to these, bronchoconstriction, which I talked about, and the hypoglycemia is another one that can cause that. And just so you know, anybody on a beta blocker, they may not even recognize the symptoms of their blood sugar being low. We talked about first, second, and third generations, and these work on it's called the intrinsic sympathomimetic activity. It's certain beta blockers bind with the beta receptor to prevent strong agonists from binding to that receptor. You don't need to know that for your exam. I just really want you to know beta blockers overall and how it can affect the body, the beta receptors. There's some non-selective versus selective. So carvedilol, Pindolol, Penbutalol. I don't see this one used too much anymore. Drug interactions, NSAIDs, although it doesn't mean you don't give NSAIDs or with these, it just means that you have to keep on the lookout for them. So NSAIDs are your ibuprofen, your naproxen, your Motrin, ibuprofen, your Celebrex, and that kind of stuff. It's an anti-inflammatory. You can have increased effects with these other listed drugs, and there's increased risk of hypoglycemia with insulin and sulfonylureas. Sulfonylureas is another drug for diabetes. That's like your glipizide, glimepiride. It can really cause hypoglycemia, your blood sugar to drop. Insulin, obviously, we know causes your blood sugar to drop. So you have to be careful if they're on the beta blockers. Again, it can hinder your feeling of having hypoglycemia. So you have to make sure you check the blood sugars very often. All right, and that's it.